Welcome to the Not Old Better Show on radio and podcast. The show covering all things health, wellness, culture, and more. The show for all of us who aren't old, we're better. Each week, we'll interview superstars, experts, and ordinary people doing extraordinary things, all related to this wonderful experience of getting better, not older. Now, here's your host, the award-winning Paul Vogelzang.
Thank you. I'm Paul Vogelzang. Today's episode is brought to you by Caraway. Good looking, clean cooking. Have you ever stood at the pharmacy counter, card in hand, and heard one word, denied? For our listeners over 50, that moment isn't about inconvenience. It's blood pressure meds. It's insulin. It's the medication that keeps you steady, independent, and in your own life. And then comes the solution. Try a coupon, pay cash, use a marketplace. Behind that advice is a system that can feel like a black box. Prior authorization, shifting formularies, different incentives, and now more and more, algorithms. AI can speed up decisions, but it can also shut a door without giving you a clear human explanation. Now add the third ingredient, social media. A nonstop feed that can take real pain and turn it into a blame spiral until people stop asking, how do we fix this? And start asking, who do we punish? We've seen firsthand how fast outrage can spread and how dangerous it can become when it's celebrated instead of cooled down. Today on the Not Old Better Show, we're connecting those dots. Insurance hurdles, AI-driven denials, and the polarization that's eroding trust. Our guest is Dr. William Solomon, CEO and founder of the Accreditation Council for Medical Affairs and a leading expert on pharma and health insurance. Dr. Solomon will explain TrumpRx. What is it? What it isn't? And why a discount price that doesn't count towards your deductible can backfire for seniors on multiple medications. We'll talk reform, we'll talk responsible tech, and we'll talk empathy because healthcare can't run on anger, and it's never too late to insist on dignity at the doctor's office. Please join me in welcoming Dr. William Solomon. Dr. William Solomon, welcome to the program.
Thanks so much for having me. Pleasure to be here.
It's good to talk to you, too. I think certainly the subject we'll talk about today, healthcare, is just on our minds always, and particularly with my audience. I think we are steeped in healthcare information. Sorting through it sometimes is a bit of a challenge. There are lots of terms that come up frequently that are unique to the healthcare process. In your role, you have a great vantage point to observe all this, to offer some perspective, and then maybe give us a little bit of help and guidance and some tips along the way to kind of how to deal with this a little better. And I want to start with a term that our audience sees all the time. So many do as well, and that's the term prior authorization. It's almost this kind of this, I liken it to this kind of children's phrase, mother may I. It's almost this permission-based kind of system that is a very authority kind of rooted. And I wonder if you tell us a little bit where the whole kind of prior authorization really comes from and what it is in plain English so that we can understand it and understand where it goes off the rails sometimes in our approval process for getting procedures taken care of.
Yeah, it's a great question. So, and it's an important question because prior authorization is the number one reason for care delay in the United States. So 1 out of 4 prescriptions that get ran by a doctor actually are not filled because of it. So what is it? It was originally designed to make sure ultimately, Paul, that the right patient is getting the right treatment really at the right time. So it's to prevent waste, any type of fraud, any type of unnecessary or unsafe prescribing. And so that was the original idea. It was to protect the patient and the healthcare system from, spending too much money on unnecessary medications. Now, where it went off the rails, and this is really important, where it went off the rails was when a lot of the health insurance companies, we call them payers, And these payers were beginning to use prior authorization really as a lever to deny claims. So they made it very administratively burdensome on the healthcare providers. It was very unclear, kind of opaque why something would get denied, or it was inconsistent, based on the guidelines. So, it's frustrating because if you're a patient and you've been paying, insurance premiums for 10 to 15 years with your insurance company, and now you've got to get permission to get a simple prescription. Now it starts to get very, very difficult for the patient because the patient may give up and may not want to go and get on the medication because they can't afford it, or it's just a lot of work and it's frustrating. Add to that the problem that most people, until we came along, the organization that I run, the ACMA, which has an accreditation for prior authorization specialists, until we came along, there was actually no formalized certification or training for this profession. So a lot of times, if you were working in a doctor's office, you just learned about how to submit a prior auth request to an insurance company just there on the job. You were trying to figure it out. And it just got kind of passed down from person to person. There was no formalized way to learn how to do that until, like I said, we developed something called the PACS program, which is now the industry standard for it. And so it's a big problem. It continues to be a big problem. And, I don't see that it's going to ease up anytime soon. And we can get into the reasons why.
Well, thank you for that, Dr. Solomon. Yeah, I appreciate that. Yeah, it's interesting. I like the word that you chose, lever. I think it's sometimes used. The word that comes to mind, perhaps used, is a wedge too between patient and kind of this bureaucratic process within the insurance company. And I wonder, in your experience with the Accreditation Council for Medical Affairs, what have you seen as some of the reasons for these delays? Is it profit pressure? Is it that wedge kind of idea? Or is it medical necessity, or just simply, kind of a coding snafu or an error paperwork?
Yeah. So it's all the above. I would say the number one reason is people don't know how to submit a prior authorization to the insurance company. That's a big reason, is that people just don't know how to do it. So they're missing documentation. It's not coded correctly. Maybe there's a box that's supposed to be checked that's not. They're not putting the right justifications in there from a clinical perspective. All of that leads to, unfortunately, delays in treatment, delays in access. But all that type of, I guess, friction, if you think about it, when it comes to the paperwork and the administrative issues, ultimately is a big problem because, like I said, if you're someone who's supposed to be getting that MRI, or you have cancer and you're supposed to be getting your radiation or chemotherapy, and now it's delayed for 2-3 weeks, in some cases that can be very serious. And so we come at it from the perspective that education is very, very important. Establishing standards for certification is very important. I'm big on that. I'm a big believer you need to have that. And so I think that's number one. And number two, I think, is looking at how the insurance companies do these utilization reviews when they're getting, a submission from a doctor's office, how they decide these things so that it's not so opaque and unclear.
Tell us a little bit about that. What is kind of happening behind the scenes, and maybe guide us a little bit. What's the one friction point, you mentioned that word friction, that you'd remove in this process?
Well, I think in general, if I look at the healthcare ecosystem as a whole, the one player that's problematic, that creates a lot of this friction, is what we call the pharmacy benefit manager.
PBM, we'll talk.
And the pharmacy benefit manager, or the PBM, the PBM, we've heard, people talk about this. Matter of fact, to his credit, President Trump addressed this in his first term as president. And he called them the middlemen. And the problem with the middlemen basically is that they have a stronghold on how the drugs get priced in the market and how they are placed in the formulary for the insurance company. Let me explain what I mean. What people don't realize is that when a drug is, approved by the FDA, what happens is that pharmaceutical company needs to make sure that their drug gets approved or included in the insurance's formulary, meaning the insurance agrees to cover that drug in the pool of drugs they're going to cover or reimburse for. But there's different tiers that the insurance company will place these drugs in, known as a formulary tiers. So if it's placed in tier 1, for example, the insurance company is more likely to reimbursement. There'll be less copay for the patient. And that makes it easier for the patient to get the drug. Now, the insurance company is making a bet here. They're making a bet on the demand. If the demand is high, the insurance company will most likely place it in a preferred status. But also they're betting on what kind of rebate they're going to get, the PBM is going to get. Now, the PBM, they get a rebate based on the cost of the drug. And I'll say that again because people sometimes when they hear that, they're like, wait, is that for real? Yeah, the answer is yes. So what happens is if my drug is $100 and you get a rebate of that $100, you get a percentage of that. Well, if my drug was $200, you would get a bigger rebate. You follow me? So the higher the cost of the drug, the better the rebate is for who? For the PBM. So the way the system is set up, it's kind of rigged in a way to want to make sure the pharma company has a higher price of the drug because the PBM wants to get a better rebate. And this is why President Trump said we need to have PBM reforms. We need to remove the middlemen. This is, we'll talk about this later, I guess, about TrumpRx, but this was this whole idea of can you go directly to the patient in some cases and bypass all of this. But this is what's happening today as it stands. And actually, it's going to get worse because now there's a push where they want to put prior authorization for patients who have Medicare Advantage. So now you have all these people. Remember, Medicare is for people who are 65 years and older. Now those people who are, many of them are on multiple medications, they need to deal with prior authorization, which is terrible. So there's a confluence of a lot of things happening that I think is going to continue to make denials much more prevalent, prior auth denials more prevalent in the healthcare system.
Let's talk about one other real looming issue, and that's AI. And I think we all feel it at various levels in our lives. I think some of it can be very good and very helpful. I use it myself, and I think it's very helpful in certain instances. But I do think when it comes to prior approvals, getting insurance claims kind of moved through the system, that technology can offer perhaps another bottleneck that people in my audience would really like to know about. And I wonder if you'd tell us a little bit about what that technology is doing in its role, kind of serving as its own kind of PBM perhaps. And then maybe just tell us, don't we have a right to kind of know when AI is present?
So let me answer that question first. Yes, right. Patients deserve to have transparency, right? Because you need to know, obviously, whether or not there was an AI bot involved in playing a role in reviewing the data, reviewing your specific situation. So absolutely, you need to have that. And I should also say AI should never replace clinical judgment. But I want to explain to the audience something about AI because I think not a lot of audience members know this, actually. And this is, one of our other accreditations and certifications that we offer. It's called the Board Certified Medical Affairs Specialist, or BCMAS program. It goes to medical affairs and medical science liaison professionals in the pharma industry. Those are the people that educate doctors, even more than the PharmaRx. People don't know about them, but those are the real people that educate the doctors. The reason why I bring it up is that we actually include in their certification a whole section on AI literacy and AI governance. And let me tell you why. Because a lot of people don't know how AI really works. Now, we know, to take a step back, what we have today is that there's a few AI models, right? There's OpenAI, which is your ChatGPT. OpenAI has ChatGPT. You have Google, which has Gemini, right? You have Anthropic, which has Claude. And those are like the three main AI models or, LLMs out there, right? Anything that anybody does with AI, by and large, I would say 99% of the time, all they're doing is fine-tuning one of those models. That's important for the audience to know, and I'm going to tell you why. Because what does it mean to fine-tune an AI model? What it means is that you're going to take that base model that was from Google or Anthropic or whoever, and you're going to upload your own data, your company data. It could be, if you're United Healthcare, it could be all the clinical guidances and, that determine your, utilization review guidelines, Now, the thing is, when you upload that information, the AI model, depending on what you upload, can be biased. And we saw this with United Healthcare a few months ago. United Healthcare, because the data that was uploaded allegedly was biased, and allegedly they had said that it was questioned about whether or not they were using the AI to sway in a biased way more denials is still up for question. We don't know. Again, it's alleged. But that's the real issue here, is that if the AI model is biased, which inherently a lot of them are, if you use ChatGPT, you know that you could have it biased certain ways. You can ask it to be biased. That's where this creates a problem, because it can actually increase the friction that we were talking about earlier with denials. Now, in the best case scenario, what AI should do, it should standardize reviews. It should be able to catch errors, any documentation gaps. It should be able to reduce human bias, because human beings have bias. Remember, we're talking about AI having bias, but remember, human beings have bias as well. Ideally, AI should accelerate turnaround times, right? All of that should help remove that friction, not add to it. However, the problem is AI itself, those large language models, they inherently have bias within them. And there's what a lot of studies that have come out showing that AI has bias. And so it's not so much about how the hospitals, the health insurers are using AI, is that the inherent models still aren't perfect, right? We haven't perfected these models. So AI should never replace clinical judgment. You always have to have some type of human being that's overseeing the decisions that AI makes, because healthcare, there's a lot at stake. It's not just a simple algorithm.
Let's offer kind of some practical advice, perhaps, to our audience, and tell us, once that no happens, once one of our members, one of our audience has said your prescription isn't covered, there's some embarrassment. Certainly, you're perhaps standing in line. You feel like you need to address that, but you're feeling stressed. You need your medication. What do they do next? Give them kind of a 24-hour glimpse into a kind of a process about who to call, what to ask for, and even what to document in this process.
Very good question. I would say there's three things. First, call your doctor's office right away, and ask them to confirm whether they submitted a prior authorization and whether all documentation was complete. So that's number one. Pick up the phone, call your doctor, and say, hey, did you guys submit a prior authorization for this request? And is all documentation there? Is anything missing? Number one. Number two, ask them, if it was denied at the pharmacy, why was it denied? What was ask for the denial code. That's important. If it was, a step therapy edit, a formulary exclusion, figure out what the reason is. And then you want to give that information to your doctor's office. And then the last thing I would say is, and this I know sounds tedious, but document everything. Write down the people you spoke to, when you spoke to them, if there's any reference numbers. That's all important, because you want to understand ultimately, if you want to go appeal the decision, you want to have all documentation there, all the information there. That just makes it easier when you're dealing with the insurance companies.
Hold on just a minute, because this next part of our conversation today with Dr. Solomon could save you real money and real heartache. In just a moment, Dr. William Solomon's going to be back. He's going to give you the one question to ask at the pharmacy counter when you hear denied, and why being told just use a coupon can feel like relief today, but cost you more and more over the year, especially if it doesn't count towards your health insurance deductible. And we're also going to talk with Dr. Solomon about the new gatekeeper in healthcare, algorithms, AI. When an AI system helps decide what gets approved and what gets blocked, who's responsible? And how do patients fight back without losing weeks of care. Let's re-inject some trust into these conversations. Plus, how online outrage can turn real pain into dangerous stories, and what it takes to bring the temperature down and rebuild this trust. Don't change that dial. Don't go anywhere. We will be right back with Dr. William Solomon. Hey, it's Paul. Spring always brings that urge to reset, certainly for us. It always means clearing things out, simplifying, making the spaces we live in feel better, especially the kitchen. Gretchen and I have been doing exactly that, and I'll tell you, switching to Caraway has made a real difference. My kitchen just feels more organized, more intentional, just calmer. And I know my people, you appreciate the details. One of the things I hear about all the time is that you love those details. You especially love the Caraway clean tempered glass lids because being able to cook and actually see what's happening, no lifting, no guessing, just clean cooking with a view. It's simple, but it changes everything. Now, more and more of us are paying attention to what our cookware is made of. Caraway is thoughtfully made without PFAS, PTFE, and PFOA. None of those elements. Those are the kinds of industrial coatings and chemicals often used to make things non-stick. With Caraway, it's a cleaner, more modern approach, and it just feels better knowing what's in your kitchen and what's not. But beyond that, it makes everyday life just easier. The ceramic surface means eggs slide right out with minimal oil, and cleanup is quick. No soaking, no scrubbing. And that's time you get back. I find myself reaching for these pieces every day, from the beautiful walnut and maple butcher blocks to the weighted grill press for crisp, consistent results, to the Bakeware Plus collection that makes oven cooking effortless. Even the kitchen timer, easy to set, even with messy hands. Might seem always to be messy. All of this just works. Caraway is already in over 2 million homes with more than 150,000 five-star reviews. Once you use it, you'll understand why. Check out the Dutch oven, too. Oh my gosh. Right now, their cookware set can save you up to $230 compared to buying pieces individually. And for our listeners, you get an additional 10% off when you visit carawayhome.com/NOB or use the code NOB at checkout. That's carawayhome.com/NOB. All of this will be in our show notes. But remember, Caraway, non-toxic kitchenware made modern. Thanks, everybody. Dr. William Solomon is our guest today. Dr. Solomon is with maybe sure I've got this correct. I like this title, Accreditation Council for Medical Affairs. So accreditation, certification, training, working within medical affairs groups within insurance companies, really health insurance expert and expertise. And I like the training aspect of what you do. In my research of you, I've heard you talk a little bit about this boiling point that we're seeing, kind of some of the anger that's surfacing over whether it's rebates or AI bias to, curb expenses or to emphasize a profit margin. And we've talked about the subject of transparency too together. So what's driving this real spike in frustration? Is it just the more denials, the more levels of kind of scrutiny and approval, or is there something else that we should know about, and perhaps even something that can make us feel a little bit better about our relationship with with the health insurers?
I think things are less human, right? In general, I think there's a frustration among people when they're dealing with these big conglomerate corporations that there seems to be less humanity in those dealings. It's a lot of AI, a lot of machines. It's very difficult to get somebody on the phone. That's frustrating for people. That's very, very difficult with people. I mean, even nowadays, it was a big storm here last week in the Northeast. You probably heard, and it was a bunch of obviously flight cancellations. And I was calling one of the airlines trying to figure out what was going on, and just to get someone on the phone, it was like they didn't want to really talk to you on the phone. It seemed like they just really wanted to push you towards the chat. But even the chat starts out as like an AI. It's an AI bot before you have to do all that before you get to a human, right? So I think in general, in today's society, there's just a frustration and not feeling like you're heard, not feeling like you're being treated as a human being. And we saw that, unfortunately, boil over with the Luigi Mangione situation, which is a horrible situation. Nothing justifies what he did, but it speaks to, I think what's more important to me, Paul, when I think about it, is people's reaction to that situation. The fact that some people saw him as a vigilante, like he's a hero, right? And there was people cheering, for him. That's scary. That's scary. So I think in general, in the society today, people are questioning authority. People are questioning, established organizations like health insurance companies. We see that now, even with the government, people are questioning a lot of things. There's people, more than ever because of misinformation or overload of information. People see, and question, a lot of events and just don't believe what they're told. So I think that leads to the frustration. And obviously the fact that today, more than ever, I don't know if you know this, but in the last 10 years, the majority of the drugs that have been approved by the FDA are specialty drugs. Now, what do I mean by specialty drugs? Specialty drug is a drug that's usually a biologic. What's a biologic? A biologic is an injectable. A lot of the drugs approved today are injectables. Like the GLP-1s, you inject them into your stomach. Why is that? Because they're large molecules, so they can't be taken orally usually. So usually you have to inject them. Why I bring that up is that those have a higher cost, higher premiums, and insurance companies don't want to pay for them. So they're good in the sense that you don't have to take them as often. Maybe you take them once a week, once a month, depending on the drug, but they're expensive and more patients rely on them. But, it's more difficult to access. So what do you do? And so all of that leads to this just increasing frustration, from my perspective.
Dr. Suleiman, you brought up TrumpRx a few moments ago, and I want to talk a little bit about this because you've described it as this searchable database. And so I wonder if you tell us a little bit about it, linking to discounts. Is it similar to the yellow card that we see, GoodRx? What is it that we need to kind of know about it so that we don't get fooled into thinking that it's something that it isn't and that we can actually get something from it that it can be genuinely helpful towards our medication expenses?
So it's very important to understand that TrumpRx, all it is think of it like a searchable discount platform. That's it. You go there and you can search and find. It aggregates all the places where you can get a medicine negotiated, the cash prices negotiated outside of the traditional pharmacy insurance channels. That's it, right? So it helps people that are uninsured. It helps people that have maybe high deductibles that are early in the year. Any patients, for example, whose medication may not be covered on their insurance formulary, the formulary we talked about earlier on. But remember, what's important to understand with TrumpRx, when it shows you those prices, it's comparing the list price to the discounted cash price. So if someone's already met their deductible, their insurance company copay might actually be lower than the cash price. So you have to really check and make sure. I'll say that again because I know it's confusing, but if you've met your deductible, your copay, what's left after the insurance company's covered for you, could be lower than the cash price. So you have to check and compare and see. Okay. And remember too that the payment you make on TrumpRx through that discounted platform will not count towards your deductible or your out-of-pocket premium. And that's important if you're on multiple medications, like a lot of your seniors. So if you bypass insurance all year, you'll never reach your deductible. And then if something, God forbid, catastrophic happens, now you're more financially exposed. So that's all important to keep in mind because it's like you can either, if you decide to defer and use TrumpRx, it's going to take you longer to meet the deductible. But if you met the deductible, you're going to pay a copay, which I would think is going to be cheaper than the cash price. So Does it help? Like I said, it helps in those specific situations, maybe where you don't have insurance or your drug just isn't covered on the formulary for your insurance company.
Is this another lever or wedge? I mean, if one of our listeners is taking 5, 10, 15 medications and they're not being counted towards their deductible, is it just a cost shift from the insurance company to the member in this particular case? And aren't we just seeing more and more of this kind of DIY, do it yourself administration on the part of members in
Yeah.
making sure to manage their own health care plan?
I would say so. Yeah. I mean,
Yeah.
it is in many ways. I mean,
Seems like it, yeah.
it seems like it is a cost shift. I don't disagree with you. I mean, I think the question is long term, if insurers,
Mhm.
increasingly are pushing patients into cash channels, it shifts that cost accountability away from the insurance company, right, onto the individuals. And so if you are on several medications, you're going to have to be much more reliant on these copay cards or these discounted channels. But the problem is, pharma companies can change these prices at any point, and a lot of times you don't know what factors are going to impact that. For instance, right now there's a price war going on between Eli Lilly, who's making one of the GLP-1 weight loss drugs, and Novo Nordisk, who's making, Wegovy and Ozempic. So there's a war going on between Eli Lilly's Mounjaro and Novo Nordisk's Wegovy or Ozempic. And, what they're trying to do basically is win over the patients on cost. Um, and that's, that can make it, tricky for patients because, again, I think it's like $475 they're at now for a month's supply. But if your drug, let's say you're on Wegovy or Ozempic, and it's covered by your insurance company, presumably that's going to be a much cheaper cost once you've met your deductible. So patients really have to, take the time to look and compare to make sure that it makes sense for them before using like a TrumpRx platform.
You've really talked about the middlemen in healthcare, especially the pharmacy benefit managers, the PBMs. What policy change would actually be felt at the pharmacy counter within a year? Would it be more transparency? Would it be PBM reform, caps on reimbursement, or something else? What's your perspective on this?
From my perspective, it's really about PBM reforms and lowering the power and the influence that some of the PBMs have, and decoupling the rebate from the price of the drug. I think that's number one. That's it. If I was going to say in a nutshell, the number one thing is remove the link between the rebate and the price of the drug so that the PBMs aren't incentivized based on that. I think that's the biggest thing. If we can decouple that somehow, then I think that makes it easier. So to me, that's number one, right? Because in the end of the day, the more people that are involved and kind of touching the dollar, so to speak, and the middleman, the more costs you're going to have long term.
Dr. Solomon, I want to talk about a hard subject. And that's a subject that has been fraught with some violence recently. It's the subject of social media and the role that it plays in kind of our public discourse that's going on. Without relitigating any single case, when we see these public reactions to high-profile violence that social media really seems to spur on, and I'm talking about Charlie Kirk, I'm talking about the case that involves Luigi Mangione and the United Healthcare CEO, Brian Thompson. What does this moment tell us about this polarization that's going on, this personal pain that exists when somebody becomes a public target as a result of the work that they do and all of the institutional distrust that is leading to some real-world harm?
Well, I think it goes back to that larger discussion that I was talking about earlier when you were asking about frustration. I think when the rhetoric shifts from, this PBM policy needs a reform to, what, this party, we've got to hurt them, they deserve harm or something like that. I think that's a red line, right? I think it's okay to question. It's okay to have mistrust, but violence isn't okay, right? Or calls for violence aren't okay. So I think we have to be careful because what I'm seeing in the culture is a very strong polarization. and we're putting people into these boxes, right? So if you're a Republican, it's like, this is what you believe. If you're a Democrat, this is what you believe. And I think that's very dangerous, because you dehumanize people into these identity groups, and that should not happen. If you're, like the United Healthcare CEO, what happened to him in that situation? It's like, okay, you're a United Healthcare CEO, you start to apply all these attributes to this person. And that's very, very dangerous when it goes into that territory. And I think you also have to ask yourself, where are you getting your information from? I'll give you a good example. About 2 weeks ago on my podcast, I had two individuals who were on the advisory committee for immunization practices. So they're the people that set the vaccine guidelines for the United States. For basically for the healthcare systems, when and how you should take vaccines and which vaccines. And I asked them, very pointed questions that people ask, right? We hear, for example, vaccines are linked to autism. We hear, hey, the COVID vaccine, how did it get developed so quickly within a year? It takes 10 to 15 years of a vaccine. Can we trust mRNA technology? Those types of things. And I would encourage the listeners to go watch that. It was actually a phenomenal episode. But those people have the data. They know the data. That's my point, right? Like when you're listening to a celebrity who says, you know what, vaccines cause autism, you have to keep in mind your source. What qualifies a celebrity or even a politician to say that vaccines can cause autism? That's dangerous, right? Because we're moving away from being a society that's evidence-based. Medicine's always been evidence-based. And until the advent of social media, doctors didn't have to worry about patients coming to them and saying, hey, you know what, doc, I just looked at my phone and, on my TikTok video, I saw, this person talking about how vaccines are really dangerous. And we see what happened. I think it was in South Carolina. There was a measles outbreak, if I'm not mistaken, because the parents, they were watching social media, thought that it was going to harm their children, and didn't give their children the vaccine. They got measles. So that's dangerous. That has real risk. So, our words matter. And I think, when it comes to healthcare, especially, putting out misinformation is very concerning. And obviously I get it, where you draw the line between that and, obviously freedom of speech and our First Amendment rights.
Dr. William Solomon, thank you so much for all your work, for coming on and talking to us so frankly about these subjects. I'll just say selfishly, we'd love to have you back. I know that your work with ACMA keeps you very busy, but this is a big issue for our audience. And as things change, as you gather more information that you think is relevant to share with us, please come on back, because we'd love to help kind of restore some of the trust and the sanity in this process. I think our audience is right there.
Thanks for having me. It was a pleasure.
Today, I want you to carry one phrase with you. Be watchful. You heard me mention in the interview this DIY nature of healthcare. Be watchful. Because healthcare is changing fast, and it's not always changing in ways that are easy to spot when you're standing at the pharmacy counter, tired, trying to get home, just wanting the medication your doctor prescribed. So here's your takeaway. Be empowered. For a few minutes a month, act as your own pharmacy benefit manager, PBM. You heard Dr. Solomon refer to that in our interview today. That doesn't mean doing this alone. It means staying one step ahead. We will have subsequent episodes about this very subject, so please listen again. But keep a simple list of your medications. Ask, is this on my plan's formulary? Ask, what's the cash price? And what's my price through insurance after the deductible? Ask, if I use a coupon or a marketplace, does this count towards my deductible? And if you hear denied, don't stop at the first no. Ask for the reason. Ask for the appeal steps. Loop in your doctor's office. Reach out to the website that makes that particular pharmaceutical and find out if they have a plan to help you get it. That's not being difficult. That's protecting your health and your wallet. And if today's conversation stirred something in you, made you angry, worried, or just exhausted, remember this. We fix what we face, and we face it best when we stay human. We can demand reform without losing our compassion. Thanks for joining us today. Our episode, of course, has been brought to you by Caraway. Good looking, clean cooking. Please support our sponsors. Check out our show notes today for more details. For more on today's episode and to hear our full back catalog of all of our episodes, we're up to just about 1,000 now, visit notold-better.com. You can also follow us on social media, on Twitter at NotOldBetter and on Instagram at NotOldBetter, and share this episode with someone who needs it. This is a production of NOBS Studios. I'm Paul Vogelzang. I'm glad you spent time with us today. Listen again soon for more on DIY ways to be prepared, to stay informed, and to keep your footing as healthcare changes for all of us. Until next time, be watchful, be kind. Let's talk about better. The Not Old Better Show on radio and podcast. Let's take care of each other. Thanks, everybody. We will see you next time.